baby. I go stand up and go look for professional help.
Drugs get young, you say what if you don't know. Say no to ref, not from my dog. Drugs get young, you say what if you don't know. The brother man used to tell a brother, one man hard drugs can kill a brother. Save your soul, one of my life, cause if you wound you, he got my life. I know that I'm tempted to light it, but I believe I can fight it. The name was Semoga about rehab. I'm going there not just to please her, but to heal me and to help me. From a COVID breath, I believe I can stop it for life. I know go wait until he wants me. I know go wait until he buy me. I cannot put I make a drop so do me. Even do something must to kill a man. I cannot put I let them kill me. I go stand up and go look for professional help. Mungu gaga Silifon Onyara Baby James baby Naibo Akode Nati Bobo Silifon Onyara Imama Wanamo she don't wanna me say you go beat us, and the only thing when they make me high. And when he high, even do I'm like he go broken. And he go say I am feeling like you run. And when he run, that's when them go they talk. And when he shell it, that fella go say, in mama wanna move. Stop it, boy. In papa wanna move. Stop it, boy. I'm waiting to worry you. Today, I already bought my suit. The honeymoon for before Takwami, but you know, yeah, in mama wanna move.
Welcome to everyone on the space. Good afternoon to all of those across Nigeria, and for those joining us from other parts of the world, I'll say good morning and good evening. That's to all members of this conversation all on the space this moment, be you across Europe, America, Asia, Middle East, and the rest of Africa. This is NDLA's Open Forum on X-Space. Some 2 weeks ago, it used to be Twitter Space, but now we're calling it, the owner has renamed it, and that's why we're calling it X-Space, according to dictates of Elon Musk. This is a platform where we share information about substance abuse and its inherent dangers. It's also a channel for us to update you about all the activities of the agency, that is the NDLA, National Drug Law Enforcement Agency, especially what we're doing to curb the menace of substance abuse and illicit drug trafficking in Nigeria, as well as getting your feedback so that we can continue to improve on what we do to serve you. This conversation, as it's often done every week, is recorded and is streamed live on our other social media handles, for instance, at NDLA01 on Facebook, as well as at NDLA_Nigeria on Instagram and YouTube. You can also go back to the conversation because it's recorded, and listen to the recording and share with others much later after the end of this space today. Before I invite our guest today, don't forget that we are speaking today, we are addressing treatment options for addiction and recovering drug use disorder patients. My name is Femi Babafemi. I'll be your host on this program today. But before we go to our guest today, who is in faraway United States, I guess she's somewhere in New York or around that area, but then let me not, I don't have to disclose her precise location, but I know she is in the United States. And before I invite her to make her presentation, let's remind or update you about some of the activities of the agency this week in our news highlight segment, which will be taken by our regular Blessing. Blessing, let's see what you have for us this week. Please go ahead and let's get the updates. Thank you.
Thank you, sir. Good day to everyone, and thank you for joining us on this week's X Space. My name is Blessing Tarfa, and here are the NDLEA news highlights for the week. India-bound couple excretes 184 wraps of cocaine, woman hides drug in private part. As NDLEA intercepts heroin, meth consignments concealed in beads, soap bars, MP3 player going to New Zealand, Greece, Hong Kong. Operatives of the National Drug Law Enforcement Agency, NDLEA, have arrested a fake couple, Mr. Ilonze Kingsley Onyebuchi and Mrs. Ilonze Roslyn Nonyelum, purportedly going for medical treatment in India for ingesting 184 wraps of cocaine weighing 3.322 kilograms, with 100 grams of the drug also concealed in the woman's private part. The two suspects were intercepted at the Screening Point 1, Terminal 1 of the International Wing of the Lagos Airport on Tuesday, 1st August 2023, while attempting to board an Ethiopian airline flight to India. Though their travel documents show consistency in their names and depict them as a couple, an NDLEA officer, however, decided to subject them to a body scan. The scan confirmed they both ingested drugs, as a result of which they were later placed on excretion observation at the agency's facility. While their travel documents identify the man as Ilonze Kingsley Onyebuchi and the lady to be Ilonze Roslyn Nonyelum, preliminary investigation revealed that the intending passengers were not a couple, but obtained the travel documents in the same surname to beat security checks at the airport. The lady later gave her real name as Ngo Bike Nkechi. During her interview, she confessed that she was recruited in her church in Aba, Abia State, where she lives. The suspect, Ilonze Roslyn Nonyelum, also known as Ngo Bike Nkechi, stated further that she is a divorcee and that Kingsley, with whom she was traveling, is not her husband, but connected only for the purpose of the illicit drug business trip. She revealed that her arranged husband, Kingsley, brought the pellets of cocaine to her in her room to ingest in the hotel, where they both lodged in separate rooms the previous day, Monday, 31st July. After their arrest, a thorough search conducted on her led to the discovery of a big-sized wrap of cocaine that weighed 100 grams she inserted into her private part. She confessed that she was promised $5,000 upon successful delivery of the drug in India. In his own statement, Kingsley, who was into clothing business in Onitsha, Anambra State, claimed he was promised $2,000 after a successful delivery of the drug in India. A further search of the agency's crime database revealed that Kingsley also obtained his travel documents with fake identity for the trip. Indeed, it was established that he was arrested by NDLEA operatives at the Nnamdi Azikiwe International Airport, Abuja, on 19th March 2022 for ingesting 100 wraps of cocaine weighing 2.243 kilograms upon his arrival from Addis Ababa, Ethiopia, on board an Ethiopian airline flight. His travel documents then contained his real name, Uwazoke Ikenna Christian. After his arrest at the Abuja airport on 19th March 2022, along with another suspect, Iro Elvis Uche, who also ingested 65 wraps of cocaine with a gross weight of 1.376 kilograms, Uwazoke was subsequently arraigned before Justice Zainab Abubakar of the Federal High Court Abuja with charge number FHC/ABJ/CR/438 2022. He was eventually granted bail by the court pending the conclusion of his trial. He is still on the court bail when he was arrested at the Lagos airport for a similar offense on Tuesday, 1st August. While Ilonze Kingsley Onyebuchi, also known as Uwazoke Ikenna Christian, excreted a total of 82 wraps of cocaine with a gross weight of 1.822 kilograms in 5 excretions, Ilonze Roselyn Nonyelom, also known as Ingo Bike Nkechi, ingested 101 wraps in 4 excretions with a bit-sized wrap of the substance recovered from her private part, all weighing 1.50 kilograms. Meanwhile, NDLEA operatives of the Directorate of Operations and General Investigation, DOGI, attached to courier companies in Lagos, have intercepted various quantities of dextromethorphan mixed with heroin, methamphetamine, dimethylsulfone, and cannabis concealed in different objects going to Europe. While 272 grams of dextromethorphan mixed with heroin going to Greece were recovered from white neck beads, 665 grams of cannabis being shipped to Hong Kong were hidden in bars of Dudu Osun black bathing soap, with 261 grams of dimethylsulfone going to New Zealand hidden in reels of weaving threads, and 1.5 kilograms of methamphetamine also going to New Zealand, neatly packed in an MP3 player after all the parts were removed and the substance stuffed as replacement. In Kano State, a woman and 4 men, Ladi Peter, 47, Umar Salisu, 38, Ahmed Nahib, 36, Ibrahim Umar, 42, and Musa Suleiman, 43, were arrested in connection with the seizure of 977.7 kilograms of cannabis sativa from them by NDLEA operatives along Zaria Kano Road, Kwanar Dongora, on Friday, 4th August, and Monday, 31st July. In the same vein, 2,445 kilograms of cannabis sativa were recovered from the warehouse of a fleeing suspect, Usman Nar, at Medina 2 area of Jere local government area, Borno State, on Saturday, 5th August. No fewer than 57,450 pills of tramadol, rofinol, and Exol 5, as well as 4,082 bottles of codeine-based syrup were recovered from a suspect, Joseph Usman, in a commercial bus coming from Onitsha, Anambra State, to Abuja along Abaji-Abuja Highway on Friday, 4th August. In his reaction to the seizures and arrests of the past week, the Chairman Chief Executive Officer of the National Drug Law Enforcement Agency, Brigadier General Mohammed Buba Marwa, retired, commended the officers and men of MMIA, Kano, FCT, and Borno commands of the agency, as well as those of DOGI, for their diligence, vigilance, and professionalism in the discharge of their responsibilities. He charged them and their compatriots across the country not to rest on their oars. That's it on arrests and seizures. Now, onto the wider activities across the country. On Tuesday, 1st August 2023, the Ogun State Command of NDLEA conducted a wider advocacy campaign for students and staff of Righteous Model College, Idiaba, Abeokuta. Through the lecture, students were given the opportunity to learn about the importance of remaining drug-free. The staff were charged to create a safe and drug-free learning environment for the students, as this is the multidimensional approach to a drug-free future for all. The Plateau State Command also on the same day facilitated a lecture on the dangers of substance abuse to an audience of 704 students in Command Secondary School, Zaria Road, Jos Plateau State. The lecture served as an educative session to implore students to remain drug-free for a better future. Still on Tuesday, 1st August, the Oyo State Command sensitized the members of Park Management System New Garage, Ibadan, on the dangers posed by drugs to drivers and other road users. The Ebonyi State Command of NDLEA on Wednesday, 2nd August, conducted a wider sensitization lecture for women of Presbyterian Church Onweke. The agency identified women and religious institutions as stakeholders in the war against drug abuse and encourages religious institutions to adopt the wider advocacy campaign in their sermons. Still on Wednesday, the Osun State Command of the agency delivered a wider sensitization lecture for graduating students of Fakunle Senior Secondary School, Oshogbo. The agency charged the graduates to remain steadfast and avoid the temptation of drug use even as they further their education. The Rivers State Command also facilitated a sensitization training for members of Nigerian Association of Patent and Proprietary Medicine Dealers at Rumodoya, Port Harcourt on Wednesday, 2nd August. The training highlighted the role of the association in curbing the supply and distribution of illicit substances. On Thursday, 3rd August, the NDLEA Benue State Command enlightened traders and members of the public at Yaikoyo Market, Yaikoyo Community, on the dangers of substance use. The traders were advised to stay away from illicit substances and instead seek better healthy living choices. And on Friday, the 4th August, the NDLEA Kwara State Command delivered a WADA sensitization lecture at Ilorin Central Jumat Mosque. During the lecture, the agency emphasized the need for worship centers to include the dangers of drug use in religious teachings. That's the update for this week. My name is Blessing, and I hand you over to our host, Mr. Femi Babafemi.
Thank you very much, dear Blessing, for the awesome newscast. Now, let me welcome everyone back from the news highlight segment. Let's quickly remind us about some of the rules guiding our process of engagement on this program today. When we approve you to be on the speaker's corner, please ensure you remain muted until after our guest presentation, and we start inviting individuals to unmute themselves to ask questions, to make contributions, or interrogate the presentation. Just a few seconds. Let's try and make it so brief so that the mic can go around. Thank you. Now, we don't encourage, please note this, we don't encourage unauthorized interruption, and we don't discuss politics here on this platform at all. So let's all remain guided so that we all can enjoy and benefit from the conversation. This is actually for the education and the enlightenment of those on this platform, as well as those who are struggling with substance abuse, or who need to know, who need to understand what this problem is all about and how we can get help for those who have this problem. In addition to our determination to update you about some of the activities of the agency. So please, let's remain focused on that purpose so that we all can achieve the whole essence of this, and would always appreciate your usual cooperation in this regard. Now, today's program will be as interactive as much as possible, and would be responding to all, that is our guest today, as well as my humble self, will be responding to all your questions and take your contributions. Please note again, on today's subject of discussion, strictly on today's subject of discussion. And so please stay calm and let's enjoy the conversations on today's subject of discussion. This is all part of our commitment to engage with everyone, that is all our stakeholders, whoever you may be, on this all important issue. This is something that is very, very key and central. Now, before I go to introduce our guest today, is someone that some of us will probably have known by virtue of the fact that for those who follow us on social media, we have already given out some details about her, and that is Dr. Adatu Tafa, who is a US-based pharmacist and health services researcher. But before we invite her, let me also quickly announce that the NDLEA call center is still very much available, still very much functioning. That is a center created to provide help for those struggling with substance abuse and their family members or friends and relations. At the call center, we have a team of licensed and credible clinical psychologists, psychotherapists, counselors, support workers, and mental health professionals, as well as psychiatric doctors who provide support in aiding recovery and managing social and emotional problems of those that genuinely seek help. That's those who are struggling with substance abuse or their family members or friends. We also need to let you know that this center has a toll-free helpline that is 8000-1020-3040. Let me take it again. 8000-1020-3040. That is the number to call if you need help. The whole essence of this is to remove that that fear of stigmatization or being judged. Here at the call center, our experts, our professionals there would attend to you professionally, and your information is kept secret with utmost confidentiality, so you have no fear of being judged or your information, your details provided being leaked to anybody outside. So it's a full, at the center, they provide you teletherapy and they guide you if need be after assessing your condition, if need be that they have to refer you to check into a rehab center. They guide you into the nearest one to you and follow up with you. Beyond that, the service center is also, that is the toll-free helpline. You have there at the other end professionals who also can provide support for you in the language of your choice in some chosen days. That is, apart from English and Pidgin, they can also relate with you or engage with you in Hausa, Yoruba, and Igbo. That is just to ensure that nobody is denied the opportunity or the needed help. And you can call from any part of the country. Just dial 0800 10203040. That's all at this point. So we go quickly to formally unveil our guest today. I'm talking of Dr. Adatu Tafa, who is a U.S. services provider. Adati is a pharmacist and health service provider. Let me not run it too fast. Adati is a pharmacist and health services research in pharmacy PhD candidate at the University of Wisconsin-Madison School of Pharmacy. She's earned a doctorate in pharmacy from Drake University with academic and leadership honors. Adati's research integrates health equity, substance use, medication adherence, and digital health into examining the care of people living with the human immunodeficiency virus, that is HIV. Immunodeficiency, that's human immunodeficiency virus, HIV. She was selected by the Office of Minority Health at the U.S. Department of Health and Human Services as a research health equity fellow. Using training in medication adherence support, Adati's dissertation is exploring medication adherence among people with HIV and substance use disorder, using a computer-mediated discourse analysis of participants using the Addiction Comprehensive Health Enhancement System, a support system, that AHS mobile application. In addition to her research, Adati is passionate about mental health. She regularly facilitates National Alliance of Mental Health Support Groups and was awarded the Miami-Dade County 2022 Award of Excellence. She's also received the University of Wisconsin-Madison Graduate Women in Science Award for her research, academic, and leadership excellence. Awesome. Great woman then. She's also a member of the Edward Bohet E. Honor Society, nominated by the University of Wisconsin-Madison. Let's put our hands together if it's possible, but unfortunately, it's not possible now. Even if we do it wherever we are, she won't be able to hear the resounding applause. That's a very great profile there. Now, it's my pleasure to now invite Dr. Adati to unmute herself and make her presentation, after which we proceed to invite those who want to interrogate her presentation, make contribution, or have some questions for her to go ahead when we invite them. That is one after another. We will definitely be inviting those interested in interrogating her presentation. But before that, let's actually even hear what she has to discuss with us this afternoon here in the Federal Capital Territory, Nigeria, Abuja. Where she is, I'm sure it's still early in the morning there. Dr. Adati, please go ahead and let's listen to you for the next few minutes. Thank you. Dr. Adati, can you hear us? We obviously not. Okay, I think we lost her. Okay. Apologies. We'll get her back now. I guess she's also struggling with her network there. So obviously this is not just this is not just this is not only peculiar to us here, except it's X-Space trouble. Okay, pending when we will be getting her back. I'm sure she should be trying to. I guess quite a number of people lost that, but again, like I said, pending when we get her back, let's quickly run through again. For those for our candidates, that's the successful candidates who are resuming, especially that by now I think those for the senior cadre by now they have fully started their training at the academy in Jos. But for those in the junior cadre who would be resuming, I think this weekend. I think let me quickly go through some of the information we have available for them. Okay. Okay, for those who would be resuming in Katsina, that's the NSCDC College of Peace and Disaster Management, kilometer. Okay, I'm trying to track Dr. Adachi now. Okay, as soon as we get that, but then let me quickly ship this in case we don't have the time. By the time she calls back, we don't have the time to provide this update for for our narcotic assistant. That is narcotic assistant. Those successful candidates. Please note that. Okay, we have Dr. Adati, but then let me quickly run through this before she stabilizes. For those of you who are within serial number 1 to 400, please remember that your resumption at your training venue, which is NSCDC College of Peace and Disaster Management, kilometer 4, Babaruga, Basari Road, Katsina, begins tomorrow. That is for those within the serial number 1 to 400 on our published list. Please note that you are resuming from tomorrow, 12th of August. That is Saturday, 12th of August. Again, for those, that's group 1. For those in group 2, that's serial number 401 to 800. Your own resumption is Monday, 14th August 2023. Please stick to the time specified so that you won't be having issues. That is for those who falls within serial number 401 to 800. That is those in group 2. You'll be resuming at your venue, that's in Katsina, on Monday, 14th August. And for those in group 3, that is serial number 801 to 1200. Please remember you'll be resuming on Tuesday, 15th August. And for those, okay, I'm tracking Dr. Adati there. I think she's been approved again. Okay, for those in group 4, that is serial number 1201 to 1600. You will be resuming Wednesday at the same venue, Wednesday, 16th August. For those in group 5, that is on the published list of successful candidates. Those in Group 5, you would be, that is those within this bracket, serial number 1,601 to 2,000. You will be resuming on Thursday, 17th August in Castina. And the last group, Group 6 there, that's those in serial number 2001 to 2,415. Your resumption is Friday, 18th August. 18th August. Please note all of this. I may likely come back to update some of the information here, but then that's about that for now. Let's come back to Dr. Adati Tafa to continue. To start her presentation. She's not actually started. We actually didn't hear her. Guess she has some network problem there. I wouldn't know that those in the US also have network problem. Dr. Adati, we're not trying to drag you here. Please go ahead, unmute yourself and make your presentation. Thank you. Can you hear me, Dr. Adati? Please unmute yourself and let's have your presentation. I guess she's still having some problems because I see her still muted. If you can hear me, Dr. Adati, please unmute yourself and let's get your presentation. Okay, that's fine. Let's continue with the information for the kind. I think she's muted. Can someone contact her so that you can. We can establish what precisely is the issue. If okay, I think she lost it. She lost the net. Okay, she's back again. Let's. Okay, I approved that already. Okay, Dr. Adati, can you hear us now?
Hello.
Okay, can you hear us now?
Yes, can you hear me?
Yeah, I can hear you now. Okay, please go ahead.
I am so sorry. Okay, I'm just going to go ahead and start presenting. I'm really sorry. For some reason, my mic wasn't picking up, so I had to uninstall and install the Twitter app.
Okay, that's fine. That's fine. One of those things. Please go ahead. Thank you.
Okay, thank you so much for your patience. So earlier on, I started talking to myself, but I wanted to talk about first the definition of what substance abuse is, what our treatment options are, what the barriers to treatment are, and then some recommendations that we have. So I wanted to start off by saying that substance abuse is very much a social as much as it's a medical issue. So for example, for diseases such as HIV or diabetes, you're able to check someone's biomedical panel and so on to see that they have a virus, or they have, for diseases of infections and so on, you're able to actually, scientifically check. However, when it comes to substance use, there really isn't a way to say someone has a substance use disorder biomedically. However, we use some diagnostics criteria, and a lot of them include social criteria. So it's up to a person to say they have a substance use disorder, or their family or their loved ones to perceive that they have a substance use disorder. However, in the United States, there's something called the Diagnostic and Statistical Manual of Mental Disorders, so the DSM, and it's a statistical tool that sort of puts together symptoms of diseases to be able to pinpoint if someone has depression, if someone has anxiety. And so there's also diagnostics criteria for people with substance use disorder. And so for substance use disorder, there are 11 criteria that the DSM goes by to diagnose someone as having a substance use disorder. So first, we see that substance use disorder is when someone is using more of a substance that it is intended for longer amounts of time. We see that if they're trying to cut down their substance use, if they're experiencing intense cravings or urges to use the substance, if they're needing more substance to get the desired effect. So this is called tolerance, when, for example, drinking a certain number of alcohol will not elicit the same effect as drinking more. So they're gaining more tolerance. And then they're developing withdrawal symptoms when they're not using the substances. And then 6, when they're spending more time to get and use those substances. So we see whether it's they're trying to go somewhere to acquire more alcohol, cocaine or heroin, and so on. And then 7 is when we start seeing negligence in places of home, work, or school. So again, this is a social issue because it's up to your job perhaps to see that you're under the influence and not performing as well. So this is another part of criteria. And then number 8 is if you're continuing to use even though it causes relational problems. And then you're giving up important or desirable social or recreational activities. And so that's when we see perhaps people are completely neglecting everything in life and dependent on that substance use. And if using those substances are getting you into risky situations. And then lastly, when you're continuing to use despite these substances causing an issue. And so, as I said, these are mostly social issues. These are heavily issues of perception. So someone has to perceive these and then go through this criteria and say, yes, I have a substance use disorder, or my family or my job is worried about my use, which is very different from other illnesses that we see. And so for our conversation today, I want to focus on a few substance use disorder that we do have treatment for in the pharmacy spaces. And so there's substance use disorder like gambling. Some people might have a gambling substance use disorder or addiction. And some people might also have eating disorders, which are sometimes put together in the same arena as a substance use disorder, but not necessary. However, for alcohol use disorders, so AUD, opioid use disorder, which includes heroin use, and then nicotine, tobacco use, which is sometimes in our spaces here considered a substance use disorder, we do have treatment to help with that. And so I'll focus on alcohol, opioid use, and then tobacco use. However, there are other things that are substance use disorders, like stimulant use disorders. So when people are taking cocaine or methamphetamines and so on, but we do not have treatment in the drug space for those. And so I would not be focusing on that. And so for alcohol use disorder also has its own criteria. And this criteria is known as the Alcohol Use Disorder Identification Test. And this actually is a way to see if a person is drinking more based on their gender and how often they drink alcohol. And I'll just quickly skim through this, and it's called the AUDIT-C, so Alcohol Use Disorder Test. And so you can, if you're concerned that you might have issues or know someone, this is a good way to sort of self-test if they're having an issue. So for alcohol use disorder, they start by asking gender, because we know the consumption for men and women are different. And then we ask, how often do you drink a drink containing alcohol? And the options are whether they never drink, whether they drink monthly or less, 2 to 3 times a month, 2 to 3 times a week, or 4 or more times a week. And so as we see, the progression is whether they never drink, maybe drink monthly on occasion, or drink a few times, or however drink excessively during the week. And so this is more about how often they drink. And then we ask the standards of drinks that they have. And so this is another way where alcohol is different from cocaine, and also different from things like heroin, where alcohol is standardized. So when you take a bottle of a beer or a wine or liquor, you're able to see how much alcohol concentration is in it. And so we ask, how many standards of drink do you have? Do you have 1 or more drink in a typical day, 3 or 4, 5 or 6, 7 or 8, or 10 or more drink? And we usually do this as, when we ask about a drink, we're usually thinking about the concentration of a beer or a wine, which has about 8% to 10% alcohol in it. And then how often do you drink in an occasion? So do you have 6 or more drinks? And so we start thinking if you have 6 or more drinks while seated at an occasion, that's also showing that you have problematic, perhaps alcohol use. And then we also ask during the past year, how often have you found that you were not able to stop drinking once you started? And so that persistence of drinking continuously once you start, which really differentiates a person that is able to moderate their drinking separately from someone that has alcohol use disorder and has that dependence of alcohol. And then remember when I talk about the DSM-5, we have that social problem. So in the alcohol use disorder test, we also ask, during the past year, how often have you failed to do what was normally expected of you because of your drinking? So that's the 5th question. And then we ask it never, less than a month, monthly, weekly, and so on. And then during the past year, how often have you felt guilt or remorse? And so we go on to these social problems. And then, have you injured someone else because of your drinking? Have your friends or doctors or your work told you that you have issues with your drinking? And so this test, the Audit-C test, is available online, and we ask patients these questions, and then they put it on a scale, and then we calculate and score that. If they have a certain standard of score, then we say yes, they more likely have an alcohol use disorder. And I will note this one thing to come back to when we talk about barriers to treatment is these things change. And so, for example, someone might go through a difficult state in life where they're heavily dependent on alcohol. And so these diagnostics can be dynamic compared to other illnesses like viral infection, which is my primary area of interest in HIV, where you have the virus in you forever. For substance use disorder, it can be dynamic and very confusing, and that's why we really need so I'm excited to be in this space. We really need all the support and all the help and all the knowledge to actually be able to diagnose a person and to be able to give them the treatment that they want. And for the sake of time, I won't go over opioid use disorder or tobacco use disorder or nicotine use disorder, because those are the other 2. So those are the 3 that I will be focusing on.
Sorry to interrupt you, Dr. Adati. Can you not skip opioid use disorder?
Okay.
Because that's very relevant to us here, please. Thank you.
Okay. All right. That sounds good. And so opioid use disorder, Mr. Femi, and just all the guests here, opioid use disorder is a very difficult one, especially just around the world. So opioid, as you know, as I think Blessing shared on the news, there's a high prevalence of opioid use disorder. So opioids are sometimes legal medications. So we have like hydrocodone and so on. And these are legal medications that are prescribed to people. For example, in the US, it used to be standard of care when you had your teeth taken out that you would have an opioid prescribed. And what we started seeing is that people start using opioid as intended. However, they have this euphoric feeling and sleepiness that's also associated with taking an opioid. And then that ends up leading or making them addicted or dependent on this substance. And so opioid use disorder, we find that a lot of it starts from the clinic, so starts from the provider. So people are prescribed opioid for a pain that is legitimate and legal, and then people start taking the opioid as prescribed, and then they might enjoy the feeling and so on and continuously take it, and then they move to the illegal opioid, because these the legal opioids are based on prescriptions and your insurance has to cover it. And so I'm talking about the US-based system here. However, things like heroin, you find it on the street. It's a less pure form of opioid. However, it can give you that euphoric feeling that you might get from the prescribed. And so we see people, usually the sort of continuum for starting an opioid use disorder, we see that a lot of it starts from getting prescribed opioid medication and then go into the illegal route. However, we also have people that start from illegal heroin from the streets, but that's less particular. So I wanted to clarify that. And then when it comes to opioid use disorder, we have screening and testing tools to talk about opioid use. So we have the biological assessment, And so that's when we talk about how much pain intensity, and the pattern and utility or location of that pain and individual, because opioids help with pain. So they sort of numb your feelings to this. And then there's also the social assessment. And that's when we look at the home, work circumstances, social function, because someone is under the influence of opioids. And then we also have a psychological assessment that looks as tool, and this is used to mostly predict if a person is going to have a dependence or not. And we see that patients have high risk if they sort of attain to having 0.4 or more scores related to their history of use of opioids. So we ask them what they've used an opioid for, how often they've used it, if it was prescribed or non-prescribed, and then how often they've taken more than the prescribed amount, or how often they've asked for more refills than required. And so that's the history generally around opioid use disorder. And so when it comes to treatment for any of the substance use disorders, we talk about medication-assisted treatment. So that's MAT for alcohol, for opioid, or for nicotine. And then we also have the social treatment options. So these are inpatient clinics where we house a person that's living with a substance use disorder that's unable to sort of really at what they call rock bottom sometimes in treat them and give them medication that helps with their nerves and so on, and helps with the craving for the alcohol use disorder. And then similarly for the opioid use disorder, we watch them for treatment. We also give them things to help with bowel movement, because opioid really makes people constipated and so on. And so we're really sort of starting re-engineering a person's life, taking them back to when the systems in their body functioned normally, and also just the systems around them, their lives and their family and so on. So this is traditionally called rehabilitation. And then we have patients that have gone cold turkey, which is just stop using substances. That's hardly ever advised. So you need to, it's helpful to do it under psychiatric care. And I know Dr. Femi was talking about treatment and so on. And so you do need the support of providers, people that are knowledgeable in this medications that you are taking. And especially we see one of the problems that we see in the US is one of the problems we see in the US, of course, is that the drugs on the street are tainted. And so you, at some point while you're taking heroin, you might not know what exactly is in the medication. And so we really do need to do toxicology reports to see what a person has been taking to able to treat them substantially. And actually, Mr. Femi, for the sake of time, is it a good place to pause? Because the other things I want to talk about is recommendation. And then maybe I can briefly talk about specifically for alcohol and opioid use, what these medication-assisted treatments are for. Please let me know the time that I have.
Please go ahead. Go ahead. You still have a lot of time.
Okay.
On your hands, yeah.
Okay. And so for alcohol use disorder treatments, we have different medications that help with that. So we have medications that help people. And sorry, I just realized that I didn't mention about marijuana use disorder, and my specialty falls very short there. We're still learning.
Already, people are already asking about that in our DM. Already asking you to talk about weed. That's marijuana. I'm glad you remember to break that in.
Okay. Yes. And so for marijuana, because it's legal, so I'm in New York now, it's legal in the US, it's legal here. There has been a lot of sort of conflict concerning marijuana, whether or not it's considered a substance use disorder. But when we've gone back to that diagnostic criteria that we looked at, people with marijuana use disorder might not be able to function because they're taking marijuana because of how it works and interacts with the body. But we do see that people start heavily dependent on it, and that dependence is a sign of addiction. We also see that people are neglecting social responsibilities and so on to be able to get marijuana, and we see that people experience some sort of withdrawal if they've not had marijuana. And so, as I said, with all of these substance use disorder, a lot of it is social problems, so we can't specifically say if a person has a problem, but we do have this test that I've talked about a little bit, that we're able to, assess whether we perceive a person has an issue or not concerning. And one thing that I've heard in recovery cycles and people that are trying to recover from substance use is when you start asking the question if you have a problem with something, it's more likely that you do than you don't. So, for example, someone that does not have an alcohol use disorder will probably considers alcohol the way the next person thinks about Coke. And so they don't see it as a coping skill. They don't see it as something they can start taking and not stopping. And so these are sort of, again, as heavily, I think one thing I wanted us to take away from this is there's a really huge social aspect to social use disorder, as much as also it's sort of medical and pharmaceutical problem. And so for alcohol use disorder, I wanted to talk a little bit about the medications that we use. And I would say the one I'm most familiar with for the people in the studies that I'm usually part of, they usually have alcohol use disorder or heroin use disorder. Okay, and so I wanted to talk for alcohol use disorder. We have medications that deter people from drinking alcohol. So we call those anti-abuse, and we prescribe it to patients. And when they take it, it actually makes alcohol feel worse to them. And so it doesn't really stop a person from taking alcohol. However, when they consume alcohol, they do not get the effects that they usually get from alcohol. Instead, it makes them sick. And so the idea of this is really to trick your body into not considering alcohol as something you go to, when you're, when you want to, or as not something you go to, but your body now thinks of it as something that's harmful to it. And so that's one. And then the goal of treatment usually for alcohol use disorder is to reduce alcohol use, and not necessarily to stop. Abstinence works for a lot of people. However, we also see that moderating alcohol use also works for people. And so another of the medication that we use is naltrexone. That's an antagonist used for people with both alcohol or opioid use disorder. So naltrexone sort of increases the activity in the opioid system. So it interferes with the reward, and the reward system where, for example, you take alcohol and it's rewarding, or you take an opioid and so on, and it's rewarding and enjoyable. What naltrexone does is it will decrease that reward that you feel related to the substance, and so it decreases your craving to the substance. And so naltrexone is used as both for alcohol use disorder and also for opioid use disorder. And then we also have something called acamprosate, and that also stops complete alcohol use. So that's especially for people that have high dependence on it and want to continually stop using alcohol. So it's initiated for people at least 7 days after alcohol use, and then you take it daily. And its efficacy, the way that it works is actually unknown with a lot of the medications that we have, but we know that it stops that transmission of, it stops the degradation of alcohol from what you want it to be in your system and the reactions that you get. And so it really inhibits that. And but its use is also, I think there's so many questions concerning how efficacious it is. And so I think what we see more in practice is naltrexone to really reduce that craving. And then we use social and behavioral skills. So we use different types of therapy to help people cope and move away from that substances. And so most of the thing is to reduce the craving. And I think, again, with respect to the time, I wanted to talk about perhaps recommendations for any of these substances and for the treatments that we have. And so I think the first thing that we talked about is really being able to assess if a person is going through, if a person has a substance use disorder. And as I mentioned earlier on, this is dynamic. And so there are changes between whether or not a person is in active substance use. And then we also see that people relapse to substance use, and that's when they go back to substance use. And so this happens it's very unpredictable. And in recovery cycles, it's always said that sometimes relapse is part of recovery. And then for our treatment options, we do have the inpatient treatment options, and a lot of church groups and also religious group, not just church, a lot of other religious group, whether it's Judaism or Islam and so on, also have rehabilitation centers that are focused towards centering the person to their own values and really actively removing them from substance use. And so we have those treatment options. We also have therapy. We have different types of therapy. We have CBT, cognitive behavioral therapy, that really helps people be more in tune with their values and so on. And we also have those extensive outpatient treatment options, and that's where people go for therapy at least 3 times a week in group settings with other individuals with substance use disorder. And so we have the medication, we have therapy, we have inpatient treatment, and then we have the option where people just completely stop, sort of withdraw completely from taking their medication. So from taking the substance, what we called going cold turkey. And again, as I mentioned, that's really not recommended, as adverse reactions might happen from the substances that a person has been consuming. And then we also have so many barriers to treatment, considering, again, as a health services researcher, I think of this as a social problem, because, well, first, a person has to identify, the family has to identify, and also then there are barriers to getting this acamprosate, naltrexone, disulfiram, and all the other medications. Gabapentin, we also see that used to help with cravings, and topiramate. These are medications that we, I don't know the Nigerian equivalent, because these are marketed in the US, so I didn't really I thought it wouldn't be helpful to start naming the list of medications, but these are the medications that we use here to especially help with cravings and so on. And so there are barriers to accessing those medications and staying on therapy. And then some of these medications are harmful for a person to continue taking while taking actively in active addiction as well. And so we have those barriers to that. And then we have really circumstances in our life that might lead to relapse. But then we also have strong systems. And so, for example, NDLEA here is a system that really helps with drug regulation around countries, and that also actually, those systemic effects do trickle down to society and a patient. And so, for example, when they're able to find sources of medications that are being sold, and when you're able to go to schools, and I think Mr. Femi was talking about, I think it was like an educational program or something, where we tell people about the risk of substance use and really help them learn not to initiate and so on. And so there's so many of these vehicles, so many of these channels that help with substance use disorder. And the recommendations, especially from a personal standpoint, if you have a loved one, battling with addiction, I think helping them recognize the problem. But also, I think one of my biggest recommendations is perhaps connecting them to someone that has gone through recovery, that can help share their own story or listen to them, because you can't really tell what the person is going. And then from a society standpoint, we continue doing the educational program. We continue telling people about the risk of substance use, but we also help people with the medications that they need and the systems that can help them actually to be able to be rehabilitated back to society, to be able to build those relationships that have been lost from substance use. And I think from a national standpoint, again, is having agencies that really work and combating the source of our drug use problem. But one thing to acknowledge is people will continuously find substance to use. I only really briefly talked about a few substances. I didn't even go into nicotine or marijuana as well. However, there are so many also other sources of addiction. Using that DSM criteria that I said earlier on, those 11 things that show you when a person is going through a substance use. So there's some things like gambling addiction and so on. There's also porn addiction, which is also huge. And there's so many other addictions that people do not recognize or have treatment for. So being able to just have the tool, I think for me, it's very important to be able to identify what a problem is, to be able to have solutions. And I think I'll stop on that and reiterate that substance use, first we have to diagnose the problem, and then we find the treatment options and address those barriers to treatment. And I would stop with that, Mr. Femi.
All right, thank you very much, Dr. Adachi. That's a brilliant presentation there, and I'm sure we're going to be taking hearing much from you because we have quite a lot in our DM already. So should we start from our DM or we should start on? Okay, let me start from because I've seen Uncle Mo in our DM and here is live and direct. So let me give him. Let me make him the first person that would interrogate or ask question today. So Uncle Mo, please go ahead, unmute yourself and let's get your contribution or question. Thank you.
Okay, good afternoon. Good afternoon, Baba Femi, and good afternoon, Dr. Adati. That's a wonderful presentation. I actually wanted you to talk about marijuana addiction, and I know during your presentation you touched on it because part of most of the problems we're having, especially up north here in Nigeria, is we seem to have so many young people that are into marijuana addiction. I have my son, who is a 300 level law student, had to be withdrawn from school because of the problem of marijuana addiction. And we've tried so many treatment options. He had been to rehabilitation, but after some time, he still goes back. You always have a relapse. At some point, he spent 6 months at 44 Army Reference Hospital. And by the time he came back, he was looking very well. Unfortunately, 2 months down the line, he had gone back. As I speak to you now, he has even left home. So I'm actually looking for a solution to this societal problem. On the part of NDLEA, they've been doing a whole lot. However, I think they need to do a lot more because some of these people that sell these substances to our young people are in our midst. And so when they carry out arrest, sometimes you see the guy is coming back to continue. So my question would be, Dr. Adati, how well do I handle a situation like this? The son going back after treatment options, going back into relapse. As I speak to you, he's 23. And then Dr. Baba Femi, I know you used to be, I think, is it NTA or somewhere? Now I have your tutor handle. You are not going to, I'm not going to allow you to drink water and drop cup, as we say here in Nigeria, because I've seen cases whereby people will be arrested and then after like a week or so, they are back on the street selling the same substances that they were arrested for. Thank you very much.
Okay. Thank you so much, Uncle Mo. I think you can hear me for your candid question and explanation. And this will be a good time to talk a little bit about marijuana addiction. As I said, in some states in the U.S., it's considered legal. However, being a legal substance does not mean that it cannot also lead to substance use. For example, alcohol is legal. However, for marijuana, so it has this TCH, which is tetrahydrocannabinol, and that's the active component of the cannabis, and it's been approved for treatment for perhaps people that have pain or cancer. So it does have effects, but there's some effects that happen that might not be helpful for a person, and that might be what Uncle Mo might be seeing in the person he described, which is they have a person under the influence or high of marijuana, as usually talked, would have like altered perceptions of mood. There's also impaired coordination. We see a lot more with alcohol. There's also difficulty with thinking and problem solving, and disruptive learning, and difficulty recollecting memories. So these are what studies have shown as those effects of marijuana. So as much as, and I think this is a slightly controversial topic, because I have friends or colleagues that use substances, use marijuana because it's legal, and however it does have this health risk, and it can also actually impact your immune system and so on. And so there are studies that have shown that it's also associated with other mental health problems, so depression, anxiety, personality disturbances, and then in adolescence we sometimes see suicidal thoughts associated with marijuana use. And then I think a big one that I hear, I'm not sure if it's lack of motivation to engage in like activities, whether it's learning, going to school, or work. So it does have an impact. And so there's this question, whether it's addictive or not, but there are studies that have shown that in about 25% it's addictive. 25% of people that use it daily and become addicted. But I can't really say how, what sample that studied was. The effective treatment with marijuana is, I think you mentioned, Mr. Mo, Uncle Mo, is rehabilitation, is taking a person away from that substances, taking them away from a source of that substances. But also I've seen people, if there's a faith group that this person subscribes to, is having them perhaps be linked to a faith group or something that helps them align back to their value, being able to assess maybe why they use these substances. But I think the first step is definitely taking them away from a situation where they would use. And then secondly, because there isn't a medical treatment for marijuana that stops the craving to use, there are things that some sort of therapy that people used to be able to replace that craving. So for some people, it's, if I'm craving to use or smoke, I drink water or I go for a walk and so on. And then I think, Uncle Mo, I might recommend recovery groups. So there's Alcohol Anonymous, Narcotic Anonymous, and these are groups of people that are going through recovery, that have gone through a program that helps them to abstain from their substance use. And they accept people that have marijuana use disorder, and so they're very open to people that have different types of substance use disorder. However, these are primarily for alcohol use disorder or narcotics or opioid use disorder, but these groups have shown to be effective in people that are willing to join these programs and work through. And lastly, I think one thing is, a lot of it is also self-efficacy. So in a person, how they perceive if they're able to refrain from this substance use. I hate to be preachy, but it really falls on that person to be able to make that decision and to be able to use the resources around them, and to be able to really abstain from the substance use if their goal is to be completely abstinent. I hope I've answered your question, but I'm afraid there isn't a solution for a particular case. Every situation is unique. But another thing is, I'll encourage you to keep trying. There's much to gain from trying over and over again, although it can be exhausting. But really, the best thing is to be there for the person and show up for them.
All right, thank you very much, dear Dr. Adati. And to Uncle Mo, the other aspect of his question is about those when NDLEA arrests some of them, and in a matter of days, you find some of these people back in the same location. Two things may likely be responsible for that, Uncle Mo, and that's one, in the case of raids, when the agency moves or storms a particular drug joint, when people are arrested there, to you, everybody there is a criminal. But then by the time we take them to our offices, we profile them. Some of them may be users, some of them may be dealers. And in that case, we separate them. For those who are users, who need help, those are people that actually need help. We try to put them through counseling or rehabilitation. That's why you find for those class of people, after some time, you find them back. Like you are not likely to want to make their matter worse by locking them off or putting them through prosecution, criminal prosecution, even though it is possession in Nigeria as of today, by virtue of our law, is still an offense, still a crime. But then we try to adjust to best global practice at the moment. So by trying to see profiling some of these people to actually determine indeed whether an individual is one that needs help or actually one that would have to go through criminal prosecution. So that explains why sometimes you find some of these people back in those places, especially when they are users. Another thing is for those who we are able to profile or determine that they are they should go through criminal prosecution and we charge them to court. We do also have the power to keep them in jail if the court decides to grant them bail. And so when they are granted bail, sometimes you also see these people back to the same spot. So those are two scenarios. Those are two possibilities that explains why you find some of these people back on the streets. But then I can tell you that I can assure you that if you come to my DM regarding the case of your own son, I'll probably be in touch with you on that to see the possibility of knowing what we can or guiding you on some of the things to do. Thank you for your thoughts there. The time we have quite a lot of requests, Doctor. Let me quickly. Let me quickly, Doctor.
Thank you very much.
Thank you, Uncle Mo. Thank you, Uncle Mo. Okay, so Dr. Adati, please get your biro and paper so that let me just read some questions from our DM. They are interesting. So I think, do you have some paper and biro there so that I can read some to you? Okay. Okay, let's take this one. First, what is the most frequent barrier to treatment? That is one. The most frequent barrier to treatment. Another one, what is the most likely cause of relapse for drug-dependent persons, and how can family play a role in mitigating this? That's question 2 from the same source. Another question from this same person, are other treatment options more viable than others? Are some treatment options more viable than others? And 4 from the same person, what should guide a person's option and choice for treatment? Mm-hmm. Are you able to get the 4?
Yes.
Okay, let me permit you to go through this, then we'll come back to the space.
Okay, thank you so much for reading the question, sir. So the first question is, what's the most frequent barrier? And I think one of the most frequent barrier is really that first step of even knowing whether or not a person has an addiction or not, being able to actively say so. As I mentioned, we have so many tests. There isn't a gold standard for knowing whether or not a person has addiction. So you might see in cases of family, loved one, co-workers that there's a huge issue of denial. And so how can you treat a condition when a person is in denial of, or a person, and sometimes it's not that the person is in denial, they actually do not understand why they're doing this or what it means for them to be constantly, whether it's smoking marijuana, drinking, or so on. And so there's really confusion without having that gold standard of being able to diagnose a person. And then what are the causes of relapse? And so relapse is very multifaceted. And one of the things that I see, especially from heroin use and for when people come out of rehabilitation centers, and I think, sorry, Uncle Mo, to use the example that you generously shared with us, but going back to whether it's friends that a person used with, whether it's scenarios, because we can't definitely uproot a person's life completely, but however, going back to the environment, there's a huge environmental factor. And so that is one cause of relapse. And second, it could be that a person is not interested in recovery. So your family might decide you should go into treatment. However, you have no interest in going into recovery. And so when you come back out, or when you're away from that family influence, then you're back to substance use. And so those two things is environmental, and then also a person's self-decision, self-motivation, and so on. And then are there options that are more viable than others? And I think this especially is important, is that there isn't. And as I mentioned, for alcohol and opioid use and nicotine, I didn't talk about cigarettes, but there are medications that help with craving. And so I think the recommendation is to use those medications that help with craving in addition to therapy. And also, if you have the resources, to take a person to an inpatient treatment, or something that we call intensive outpatient treatment. So that's a person is coming to a group to talk with a psychiatrist or a therapist 3 times a week. So their job completely during that time is actually to recover. And so you're taking, as a family, I'm giving an example as family member, you're taking them to extensive outpatient treatment several times a week for several months. And so it's a combination of all pharmaceutical and therapy, and if you have the option, inpatient treatment, to really uproot a person from that environment. And I'm sorry to say, I wrote the first 2 words of the 4th question. It says what guide, but I don't know what the rest is. What guidelines? Mr. Fami, can you please help me? I thought I could read my handwriting. Or if someone remembers, I think perhaps what would I recommend for a person? And so I think I'll go back to the most valuable one is a combination of therapy, whether it's inpatient treatment or outpatient treatment, medication that help with craving, and then really support of loved ones. And I will, I think I've answered all those questions.
All right, thank you very much. Awesome, you there, Dr. Adachi. Okay, let's quickly. I have seen somebody on the space raising her hand, and also in our DM simultaneously. So I guess her own case is peculiar, or is very particular. So she's. Let's give her that opportunity. That Nelly Ada Ndiushe Izogu Agu. Please unmute yourself. Let's hear from you. Nelly Ada. Okay, let me read. Maybe I need to read a question so that she won't have.
Hello.
Okay,
Hello.
Go ahead. Yeah. Yes, okay.
Yes, good afternoon. Good afternoon so much. I'm going to make it very brief. I'm a parent that has had issues with my sons concerning addiction. I will tell you the problem I have with NDLE. The problem is not giving strong sanctions to those who are peddling these drugs. I can tell you what my experience was. My son was actually living in the place. 2 of them, when I battle one and that one gets better, the other one take up. So it has not been easy. I cannot wish what I went through to an enemy. Many of your staffs are culpable. They come here, they collect money from them. I'm speaking from experience, please. My sons told me what is going on. Are you getting me? Then, why can't they destroy those places? 2, why are doctors in the hospitals being allowed to say this, to have private rehabilitation centers? These doctors run their own private thing, thereby not pay much attention to the federal hospitals. And they make their own payment out of the reach of the ordinary Nigerians. There are so many barriers against Nigerians whose children are being allowed the of this. And not only that, many of these, some of them are also users. They even make those children to take it home with them. So you see, the problem is a hydra-headed one. Just to Let me say, like 3 weeks ago, I had a case of going to one of your former director's place with my son. And it wasn't that easy. The money is very expensive. Can the government help us? Can the government do something? Our youth are wasting. Wasting.
Thank you.
Please, I have to stop here. Thank you.
Thank you, Nelly. I think let me quickly respond to her. You can mute yourself now, Nelly Ada. Please mute yourself so that you can listen to me properly. Okay, now let me quickly take care of some of from what I have got. We really sympathize with you in view of what you are going through with two of your sons battling substance abuse or addiction. But then again, we also have to, because from what you have done now, maybe as a result of what you are going through, you have practically blamed every other person except where they came out from. That is the home. Now, you talked about no strong sanctions, that NDLA is not giving strong sanctions to those who are dealing in this. NDLA can only arrest, investigate, file charges against them in court. It is not the agency that awards punishment. The law already stipulates what punishment should be given to these people. And if you have been following us, you will discover that we're actually at the vanguard of advocating for the amendment of the NDLA Act to further strengthen the deterrent effect of the punishments. That is especially the issue of the option of fine. That bill, the amended bill, was passed by the 9th National Assembly, but unfortunately, before it could be assented to by the incumbent president, the time had lapsed, the 30 days window had lapsed. So now the bill is back to the National Assembly, and we're hoping that the 10th National Assembly will quickly pass that, and this would further help probably to take care of some of the complaints you have made here, especially strong sanctions. More often than not, you see some of these people when they are prosecuted, and we have in our own prosecution, we have almost 90% conviction rate, because when we arrest people with evidence. So it's very clear. Exhibits are provided and prosecution diligently done. But then when you are not the judge that will sit on your own case, so you can only take this matter to court, prosecute the case and allow the court to determine what punishment based on the laws of the land. But then more often than not, you see some of these people are given the option of fine, which they pay, and they are back on the street. So that's probably informs why you think is the NDLA not giving them stringent punishment or sanctions. That's that. Again, you see some of, like we often say, it's not enough for us to shift responsibility. I can understand your pains or what you have gone through, but then again, that's why we also advocate. We ask from the beginning, when these children are still young, when they are growing up, that parents need to wake up to their responsibility, to intentional parenting, not when the problem has become a big one, then you now start running scatter. It becomes compounded and complex at that point. That's the honest truth. We need to admit this. I'm sorry to say this, but I need to say this not only for your benefit, but for the benefit of quite a lot of parents out there who will fold their hands when these problems are developing. We close our eyes to it, and when it becomes a big one, then it goes out of, it goes beyond what we can control. Then we start looking for help. Now you are probably stuck, no resources, no funds again to take care of them, and the available government institutions cannot take care of all of these people. So you have to, in some cases, you have to depend or rely on some of these private sector, privately owned rehab centers. So that's, and government does not control these privately owned rehab centers. So you have to pay for the services there. That is why we often say parents should wake up, do what they need to do when these children are still growing up, so that you won't be facing the kind of challenge or the kind of difficulty you are facing today. But then again, I will also say, Madam Nelly, that if you know any center or any joint around you, or where you think some of these problems, some of the things you say, please come to my DM. Give me some of this information. I can tell you that we'll definitely take action. And if we have any officer that has compromised his oath of office, we'll definitely go after such a person. That you can rest assured. Thank you very much for that. Let me spare Dr. Adatif. I don't think I want to bother her with that. Okay, let's go to. Okay, let me give the. Let's take from the diarist, the Niger diarist. Please go ahead quickly. The Niger diarist, please go ahead. Yes, you are raising up your hand. I've given you. I'm passing the mic to you. Unmute yourself and let's hear from you quickly. Otherwise, I'll go to the next person. Okay, let's go to Aminu at Aminu Park. Please go ahead, Aminu.
Okay, so good afternoon, everyone. Good morning, Dr. Adachi. I want to ask about, as a professional, I want to ask you about some of the drug that, for example, in Nigeria, some of the drugs that some people abuse. For example, it's not actually illegal, but there's a way they use it to abuse it. For example, some people use they take Tom and like Acera or Sprite. It gets them high. Some people, I don't know, they inhale petrol, like petrol makes them high, and building oil paints and other things. So I want to hear your opinion about that. I also want to ask her opinion about the nitrous oxide that's been a menace now in Nigeria. We call it laughing gas, where they put it inside a balloon and be inhaling it. And also the last thing I want to ask you about is there is someone that once told me that most of the people that they take to rehab, is a professional, but I want to hear your own opinion, that if someone wants to stop, wants to actually stop abusing drug, that's when rehab usually works. But if that person doesn't want to stop, if that person refuses to recognize that they've been addicted and they are showing no signs of stopping, for example, they don't want to go to the rehab, but then they have been forced and they're taken to rehab, that even if they come out, no matter, even if they spend 5 years in that rehab, if they come out, they will still relapse. So I just want to hear your opinion on this. Thank you very much.
Thank you, Aminu. Over to you, Dr. Adati. Then I'll come to, I've seen Ezel, right? Ezel Mental Health Foundation. I've seen you in our DM, and I've also seen you on the speaker's table. So after Dr. Adati's response, then I will come to you. Please go ahead, Dr. Adati.
Okay. Thank you so much for your question. And, I think you bring up a very important point about drugs that are sort of made illegal drugs, or drugs that are created and consumed. And so we do have a lot of that issue. So you talked about laughing gas, you talked about, I'm trying to think of the other, Tom and so on. And so there's so many makeshift ways to create drugs to get high, and that definitely still falls on the spectrum of drug abuse. I think your question is for me to perhaps just make a comment about that. And so there's something that we call polysubstance use. And so that's when a person uses more than one drug. Usually a person that has a substance use disorder, sometimes they have a DOC, so drug of choice. So we usually ask people, what is their DOC? And so a person might say alcohol, but then you see that they're taking some street drug. We have things, so many different street drugs here, and so they might be taking one street drug or another. And so those are even more complicated cases. And I think, as you mentioned, we might see it in Nigeria, perhaps in more adolescent group that do not have access to some of the legal substances or some of the more expensive substances. So they're creating whatever they can for a similar effect. And so a lot of that creating your own substances to consume also has some systemic issues with it, including poverty, access to other substances, and so on. And so I don't know if I can say a solution to that. We treat it the same way as we would treat other substance use disorder, but we acknowledge that it's polysubstance use where there are more substances than not, and that's when I talked about toxicology reports. So when we do drug tests, urine tests, and so on, to be able to see what substance is in this person, which of the substances could be very harmful for them if they stop taking it immediately. So we have to taper down. For some drugs, we have to still give the person little by little to be able to take them off of it so that it does not shut off their system completely, for lack of better sense. But that's definitely an issue that you mentioned. We see it in younger populations and populations that have less resources to be able to finance other of these substances. And then your next question, you wanted to ask my opinion about drug rehabilitation and rehab centers, and you said that, no matter, even if you take someone, if they're not willing to change, they would not change. And so some of my my research is health services research. We have something called it's a theory of the theory of change. So let's say our goal is to stop someone from taking a substance, or reduce their substance taken, or stop their substances from harming them and their family. Maybe they don't want to stop completely. There are changes that have to occur. So first, as I said, a person has to know that they have a problem, and then they think about, there's pre-contemplation. That's when so these theories talk about change that occurs before you actually, so there's pre-contemplation. Sometimes a person starts thinking about, do I actually have a problem or not? And then they accept that they have a problem, and then they start thinking of a solution. So they're contemplating a solution, and then they enact. And so these things occur at certain stages. So you're right, a person might be sent to rehab that does not even know that they have a problem at all. Their family sees that they have a problem, or their work, and then they start to recognize. And then, so that's when they start pre-contemplating. So for someone, that first step is only ignited when they go to rehab and actually see other people going through rehabilitation. And then that's when it kicks in that they have a problem. So they might spend 90 days in that rehab at that first stage of just acknowledging that they have a problem. It doesn't mean that they're at a stage where they stop using a substance. But I think for me personally, as you asked for my opinion, I think it's still worth it that that person actually has taken one step, knowing that they have a problem. It might take another rehab, taking them to rehab again, to say, okay, now I have a problem, you know what, it might be worth doing something about it. And then they start thinking, about a problem. So it might be the second or third. And I've seen people that have gone in and out of rehab. I've seen people that have never gone through rehab and have had years of recovery. And then I've seen people that go in and out of rehab like a revolving door and still are not recovered. That it could be that, as you mentioned, maybe they have no intention. It could be that they have intentions, but they're back to that environment where they used and started using, or they were back to a partner that they used with, or situation and so on, and they started using. So I think, I don't think we can say for sure that if a person does not want to change, taking them to rehab will not change them, because a lot of things happen in rehab. It could be starting to acknowledge that they have a problem. It could be seeing other people that have had problems. It could be someone telling you, this is your first time in rehab, this is my 10th time. Please, please use the resources to help you change. It could be someone opening up and sharing. And so I think we shouldn't really, I know it's very hard and it's a very difficult thing to rehabilitate a person, but really trying over and over again. I know it's resource intensive, consuming, but really helping them. You can't for sure know what's going through a person, but as I said, we use theories of behavior to be able to understand where a person is in their recovery, whether they know that they have a problem, whether they're willing. And so rehab really helps moving a person along to get to that stage. And for some people, it might be a lifelong thing. And I would stop at that, because then I'll start many other personal opinions. But I think I'll stop with that rehab does ignite something, and it's helpful whether or not it doesn't stick the first time.
Thank you very much, Dr. Adati there. We have barely 30 minutes left, and so I want to try as much as possible for us to maximize. Darius, you are still raising up your hand. We have quite a lot of other people. Please, let's give the next opportunity to Excel Mental Health Foundation. Please go ahead. I've seen your messages in our DM, and here you are. Please go ahead, Dr. Adati is ready for you.
Thank you very much, Mr. Femi. Good afternoon to you all. Thank you, Adati, for the wonderful presentation. My name is Dr. Abdullahi Abdul Wahab Yaku. I'm a psychiatrist with the Ahmadu Bello University Hospital. Actually, I wanted to share some experiences we have here that is quite different from what is obtainable elsewhere. Like, for example, the issue Aminu raised and the issue Dr. Adati has just spoken about in respect of somebody not willing to go for rehabilitation and the person going for it and going back to the problem. Actually, the ideal thing to do is not to rehabilitate somebody compulsorily. Usually that is one of our biggest problems here. Somebody has substance use problem. The person is bundled to the rehabilitation center. The person doesn't believe he has the problem, but the family wanted him to be rehabilitated at all costs. Usually what is supposed to be done is, the first stage is motivational interviewing, where these stages of change can take place. Sometimes, if you want proper rehabilitation, sometimes the motivational interviewing can take the first month or the first few months before the person actually becomes motivated to accept the rehabilitation. When somebody is not convinced that he or she has problem, the person can stay in the rehab center for months, comes out, and go back to the same problem. That is one of the problems we are facing. Secondly, the society tend to look at substance use disorder as a moral problem. That medical aspect is lost on them. They do not believe it can be a medical problem. They just believe it's a moral problem. And so if somebody is using substance, he must have a moral problem. And this leads to a lot of stigma. And that is why a lot of them are resistant to presenting themselves for treatment. And that is why in my comment, I did say that the biggest barrier to treatment, either substance use or mental health problem, is the stigma, the societal stigma. Until we address that, we will continue to have this problem of resistance, because the person is worried about what the society will say about him or her, what the family thinks about him or her, or something like that. So we need to deal with this issue of stigma and understand that these problems can be medical. Like the first person complained about his son having a cannabis use problem, being rehabilitated, back, to the use again. Usually cannabis is considered a gateway drug. That is one problem. It's a gateway drug because people who use cannabis, they have this tendency to go on to use other more addictive substances, and that can complicate their treatment. That is one. Two, people who use cannabis has been found to be associated with psychotic illnesses. That is someone who already have the risk factors of developing psychotic illnesses like schizophrenia. The use of the cannabis can actually tilt that person into a frank psychiatric illness. And there is a bi-directional relationship between this mental illness and drug use. So if the cannabis use have tilted somebody into something like schizophrenia, the person can become more prone to using that cannabis or other substances. So these people can use the substance, what we do call as kind of form of self-medication. Because when they use these substances, sometimes they feel a little better with their symptoms. For example, somebody who has schizophrenia is hearing voices, hallucinating. The use of cannabis or tobacco sometimes can dampen the voices. So for them, it's like self-medicating. They feel better when they use. So this can lead to them wanting to use it more. So they need to be a holistic treatment, both that psychiatric problem and the substance use disorder.
And that is all on our conversation this week.
Another thing I want us to look at is there are a lot of these substances that are being used in our environment that are not conventional. For example, let me give an example of what happened. there is a secondary school we went to do an outreach program to raise awareness for mental illness. And there was this young boy that admitted to using substances. This is a boy in, I think, JSS1, yes. So I was surprised. I asked him, where do you get money to buy these substances? And this boy told me that, no, they don't buy. They go to a dump site, pick up rusted metals, boil these metals, and drink the water and get some kind of euphoric effect. So sometimes in our environment, there are quite a number of substances being used that even if you do urine toxicology, you are unable to detect them because they are not conventional substances, and kits, that is testing kits, have not been developed for them. So that further complicates, the treatment processes. It's quite difficult to keep track of some of these substances that these guys are, bringing up every day. So it's really a problem. The last thing I want to mention is what? Rehabilitation, even before the start of rehabilitation, I think patients and their families need to understand that even in the best of centers, the success rate is about 36%. That is, only 36% of people will go through rehabilitation first time and remain sober. That is, and do not go back to the substance. So sometimes rehabilitation may require the person to do it several times. The fact that somebody has gone through rehabilitation and the person have relapsed doesn't mean the person will not benefit again if the person goes back to rehabilitation. Sometimes it can take 2, 3, or 4 times or more for someone to actually go through rehabilitation to remain sober at the end of the day. So we need to understand this, that the success rate, in fact, one of the most difficult things to treat in the mental health space is addiction. So rehabilitation and relapse, they are one, in fact, they are almost inseparable. You rehabilitate, and you should have at the back of your mind that people can relapse, and they do relapse, and majority of them will relapse. But of course, as they go back for rehabilitation, the chances of them remaining sober increases. So we should not be quick to give up on them. I understand how difficult it is. It can have so much emotional distance on the family and friends, but let us do as much as we can to help these people, really. So that is what I actually wanted to say. And then there is one thing I wanted to mention also, that we have quite a lot of differences when it comes to what is obtainable in our environment and what is obtainable elsewhere. For example, if you look at the opioid addiction management, in our environment, if we were to use substitution treatment, we will be in another problem. Substitution treatment is just given one form of opioid, which you consider less, that have a higher half-life, to replace it with what the patient is taking, or you give an oral one to replace an injectable one. If you were to do that here, an individual can go to a center that is giving replacement therapy, collect, go to another place, because we don't have the capacity to monitor. And that is why sometimes we avoid using these approaches because of the peculiarities of our environment. Perhaps in the future we may, get to that level, but as it is now, it is going to be very difficult for us to implement such treatments as replacement therapy. So thank you very much for giving me the opportunity to talk.
Thank you very much, Dr. Abdullahi. I already put down some things. I believe you still have a lot to share with us. We'll most likely be bringing you on this space sometime very soon, because I just kept quiet and continue to enjoy your intervention there. Definitely we would, one of my colleagues will be contacting you any moment from now at the end of the space, so that we can get you scheduled for one of these conversations. Definitely you have quite a lot to offer there. Thank you once again, Dr. Abdullah of SL Mental Health Foundation. Okay, Dr. Adati, you have something to say about Thank you.
Yes,
Dr.
I think
Adati?
Yes, I think Dr. Abdullah, you brought up very excellent points. I do, and you're in the practice field, so you work one-on-one with patients. I personally only research, so I have some limitations. But statistics and studies. I think one thing I would want we can talk about this offline is the gateway myth that says that marijuana leads to harder drugs. There are no studies that really there's scientists, researchers, psychiatrists, everyone in the space is divided on that, on whether or not marijuana leads to harder substances. There isn't really anything that shows that there are correlations. People that use marijuana might use other substances, but it's not for sure a gateway to other medications. And I think you spoke about medication assisted treatment, and that's when we give less intense opioid, and we can talk about the mechanisms of action of those opioids. So medication assisted treatment to help someone with heroin abuse, for example, here we give them Suboxone. And you did talk about the limitations that someone might go to one clinic, one methadone clinic, and then go to another to collect, and they're actually just collecting the substances. And I think Blessing warned me not to share my personal stance, but I think I would share this, and it's to say that personally, I think that the goal for substance use treatment should honestly be to be able to, it doesn't have to be sobriety completely. The person does not have to completely stop using the substances. And if they can, if the substance, if there's a way that they can use it that does not interfere with other social, the interactions and so on. For example, people drink leisurely and they do not have an alcohol use disorder. And so we can be able to, so not everyone that uses alcohol should we say they shouldn't use alcohol completely. The same way, not everyone dependent on opioid should we say stop completely, or you're failing treatment, we have to take you to rehab again and again. If we can find a middle ground that helps someone to be successfully in treatment and be able to function. And so in the US, and that's what the psychiatrist just spoke about, is we have these methadone clinics where we help people addicted to opioid and substances to get a version of the medication that is not as harsh and does not present as a euphoric feeling, but it's still an opioid, but it's not the one that would make a patient pass out for years and for days and so on. And so we do have these are considered treatment option, although they're still given a form of opioid to a person. And this treatment has saved a lot of people from heroin overdose. They've saved a lot of lives, but as he mentioned, we do not have that infrastructure in Nigeria, but that's also available. And so to me, it's finding something that helps the patient and not necessarily saying, if you see someone with an alcohol use disorder drinking something that's like, oh, they've relapsed, their life is over. No, it's, are they able to moderate their drinking? For some people, maybe. For some people, maybe not. And so being able to find a middle ground and being, personalize that to what the person wants to achieve. And that's what I will stop on. But Mr. Femi, if you can help me moderate the other questions.
Thank you. I'd love to also correct an impression there. Indeed, there are already MAT centers, that's medication assisted treatment centers in Nigeria as of today. And I also know that there is a process ongoing between the federal government and also our partners, UNODC. I know the agency, that's the NDLA, is also involved in that process of also ensuring properly making this part of the treatment and officially part of the treatment plan arrangements for those suffering from drug use disorder or addiction. That I can tell you. Okay, quickly, let's go to, the time is running so fast. We have barely 10 minutes. Let's quickly come to our own commander, Bashir Ibrahim. Let's get your intervention question. We have quite a lot of hands up. I'll come back to those raising up their hands. Let's get our own Bashir Ibrahim for intervention.
Thank you very much, dear me and Dr. Abati, for your good presentation, and equally Dr. Abdullahi. Good enough. Two areas I had really wanted to talk about is polydrug users, which has been addressed, and cannabis being a gateway. Be at is that it's may. The UNODC country survey that was done shows that 1 out of every 3 cannabis user become dependency. They actually did a treatment. That's for doctor's information. She was not sure where she was talking. Now, my main point here will be addressing the family. Most of the times, when they take family for, especially the first person that talks about her children and the other woman, most families accept themselves from blame or from being part of rehabilitation process. You call them for family counseling, they don't come. Meanwhile, some of even family members are enablers. That is one. Two, they don't even feel that follow-up is necessary. Once somebody is admitted for treatment in the first instance or into a rehab center, once it's been released, they call it outside trial. There's supposed to be a follow-up. Either go back to the center for a follow-up, or from the center they come to the house to see how the person is doing. But the family cut out that chain completely. Once they go back home, they feel that the person is quite all right. Even in normal medications, you still go, the doctor will tell you, come back for follow-up. As family members, we are very poor in doing that. So recovery become a big challenge. Equally, good enough, my chairman chief officer during his period now has been laying much emphasis on prevention. You talk about substance of abuse. We are not talking about conventional drugs now. We're talking about other substances that are not even legislated. Now, what do? For us, the best way out now is prevention. So I feel while we are laying emphasis on treatments and what have you, we should be talking about prevention. We're talking about the role of parents, which DMA has talked about. We're talking about the role of the community leader, the role of traditional leader, the role of the religious leaders, so that we can actually collectively address this issue of substance use. For want of time, I think I'll stop here. Thank you very much for the opportunity.
Say something to that, or we should.
Let's go with the question. Thank you so much, Mr. Bishir.
Okay, I have, okay, let's have all regular Perpetua, Inamdi Mala Perpetua, please unmute yourself. Thank you, Perpetua, Nnamdi Emmanuel there. Adachi, would you want to say something to that before I go to Otumba GCFRN? We should slide?
Let's go on. Thank you so much for sharing. Just to respect the time, but I appreciate the conversation. Thank you.
All right, thank you very much. So let's take, I guess this may be our last, the last question or contribution. Let's take that from Otumba GCFRN. Please go ahead.
Yeah, thank you so much. Thank you, Mr. Femi, and thank you, Dr. Dati. It's really an honor to hear from NDLE. I was in a space when I saw this space. I had to leave and come here. I have a question, but it's unrelated to the topic. The question is marijuana legalized in Nigeria? If it is no, then why do our artists, because most Nigerian artists, they promote marijuana in their videos, and I think this is serve as influence to the younger generation. You see them on Instagram Live, someone is smoking weed and is making a live video. What is the role of NDLE here? Is it allowed or something? Then also a suggestion so that I can wrap it up. I would like if this program or this space can be maybe weekly or every day or something to educate the youth, because a lot of drug abuse is going on in that country, and it's really a thing of concern for me. Thank you so much. Thank you
very much, Otumba GCFRN. I can tell you that this space is a weekly program. It comes up every Friday, 3 to 5 p.m. So I guess you're just getting to know it. So it's actually a weekly program. We engage a lot of our target audience via this platform. And is marijuana allowed in Nigeria? I think, this goes straight to me, not Dr. Adati here. No, actually that if you look at the National Drug Survey result that was published in 2018, out of 14.3 million Nigerians that abused illicit substances the previous year, 10.6 million of them abused cannabis. 10.6 million, meaning that cannabis is actually the most abused. And so in Nigeria today, given our peculiar situation with security challenges, cannabis is not what anybody would ever think or dream of legalizing at the moment. That is one. Two, the artists who are promoting, glamorizing, making it appealing to their followers. Indeed, we're not empowered by law to determine or to control what they post, even though we have some other government institutions that may have some level of control over this. And I can tell you that indeed, just as we dealt with the issue of laughing gas, that's nitrous oxide recently, we are working on this as well. And I'm sure in a matter of days or weeks, there are some developments happening that I may not be in a position to disclose some of these things at the moment. But I know indeed that the agency is working hard on all of this. I've also warned we want them that particularly those influencers and artists who are glamorizing or glorifying the use of these illicit substances, that they have a role, they have a responsibility as role models who quite millions of young people look up to as their role models. So they have a responsibility, and we keep a tap on them. For those that we believe we can work with to give to give the right message to their followers, we're working with them. That quite a number of them are giving out some positive content out there on their space, on their handles. And for those that are doing otherwise, we'll continue to encourage them to have a change of heart. And for those who are adamant, we keep a tap on them. And anytime we were able to lay our hands on them for doing the wrong thing, especially when they're in possession of this, definitely they will have to face the wrath of the law. But then for now, cannabis is not allowed. That I can assure you. Thank you very much for your intervention there, Otumba GCFN, and we look forward to having you join this conversation every week by the grace of God. Thank you once again. It's past the hour, and we have quite a number of people still raising up their hand requesting, but then we can't stretch it beyond now. That's why we do it weekly. Whatever we cannot finish one, we'll always have another opportunity the following week to continue. And the conversation continues, it's never ending. And before we draw the curtain on today's conversation, let's give our special guest, our guest speaker, Dr. Adati Tafa, who has been with us in the past, in the last 2 hours. Let's give her the opportunity to give a parting shot on the conversation today, and thereafter we'll come back to appreciate everyone and close the program. Thank you. Now, Dr. Adati, please go ahead and let's have your final thoughts on today's conversation.
Thank you so much for the opportunity. I want to thank everyone for attending and those for contributing and sharing, Uncle Mo and Nelly for sharing your own personal stories, and Amina and Pepper and everyone that really joined in on the conversation. I've also learned a lot. I think one thing that I picked up on is especially polysubstance use and substance that we do not have toxicology reports for. So that's something I've not really had much experience with. So I would definitely look into that. And I want to just share my own work looks at substance use amongst people living with HIV. So we use digital health interventions to help them continue to engage in their HIV care. And so you can reach out if you want to learn more about that. But I definitely do enjoy research and volunteering in this space of substance use and addiction. And I think we've said it over and over again, but I do want to reiterate that substance use is very much a social problem. And as we've mentioned there, helping people starting to know that they have a problem and letting them know that there's support and having family support and siblings and so on. There's so many people in community. We're all we all live together in this space at this one time, and so really being able to stand up and support one another is very essential, and making sure that we help people know that recovery is possible, and there's so many things to help them with that. I think I would stop with that. I really want to thank you, Mr. Femi, for facilitating the conversation, and NDLEA for really having me on this platform, and for the amazing work that you're doing in not only medication assisted spaces, but legalization and education among substance use. Really appreciate that. Thank you so much.
Thank you very much, Dr. Adati. There, will appreciate you for the time spent with us and for the knowledge shared. Dr. Adati Tafa is a US-based pharmacist and health services researcher. Don't let us forget that's a very good ambassador of Nigeria out there. She is indeed a Nigerian, and I can tell you she's someone that has been doing awesomely well out there, winning awards and fellowship out there. God bless you. Thank you for what you are doing. We look forward to having more of your contributions on this space, and to the development of our fatherland and the benefit, most importantly, the benefit of humanity. Thank you once again, Dr. Adati Tafa. I cannot mention everybody, but for a few people that I noticed some of their contributions, let me appreciate Uncle Mo. I've told Uncle Mo, please, after this program, just come to my DM. I would love to provide some guides for you. Our own here is to provide support and help those in need, especially in regard to your sons. Again, we also like to appreciate Nelly Ada Unduishe Izogu Agu. Thank you, Madam Nelly there. Also, we'll continue to keep a tab. We're always available. Any area you think you need our help, rest assured we'll we can do for you. And if there is information you want to share with us so that we can also help your community or environment get rid of those dealing in these illicit substances, please feel free, get this across to our DM. We'll definitely do the needful. And again, thank you, Aminu. Aminu was awesome in his contribution and question also. We appreciate Dr. Abdullahi of, definitely we have our eyes. I've already told my colleagues to slip into the DM of Dr. Abdullahi there. He has quite a lot to share on this space, so we'd like to bring him as a guest. Thank you, our own commander there, Commander Bashir Ibrahim. Thank you, our regular Perpetua Nnamdi Emmanuel. Thank you, Otumba GCFRN. Guess he's also joining us from out there somewhere in Europe or in America. Thank you for all of you joining us from across the world. We appreciate you. We know that for those who are early in the morning where they are or late in the evening, we appreciate all of you. But we'd like to tell you that once again that this program is recorded. You can always go back to our handles to listen to the conversation again. If there is anything you missed, if there is anything you didn't hear properly, you can always go back to listen to it again. And more importantly, share with others. There is that theme of World Drug Day, I think some 2 years ago. Share facts about drug, save lives. So let's share draw the curtain. I like to say in close that please stay safe. Let's all avoid going or getting into substance abuse. Let's live a healthy life. Thank you. Do have a wonderful evening and a great weekend. Bye-bye from me.
Thank you very much, sir. And as you rightly said, this brings us to the end of the program. For more information about the agency, our listeners can visit our website, www.ndlea.gov.ng, and perhaps our social media platforms at ndlea_Nigeria on Thread, X, Instagram, and Facebook. On Facebook, it is at ndlea01 rather. Do join us sometime next week for another edition of this wonderful program. Thank you.
Gotta what I handle you go just die through it. But handle you go just die through it. Ecstasy handle you go just die through it. But handle you go just die through it. Drama handle you go just die through it. But handle you go just die through it. When cocaine handle you, when codeine handle you, when it handle you go just die through it. When Black Mamba handle you, when Ref not show you shade it. When he handle you go just die through it. No, mama, no wait until them handle you. When he handle you go just die through it. Paradise, Mr. Metal, when them handle you go just die through it.